Here's the defect. Here's the defect. But as you can see here, there's no keratinized tissue. Oh, 1 second. Oh, I need the other one. There's no keratinized tissue here. Here's the bone. Implants. No keratinized tissue here. Okay, you can do a free graft. This is a strip gingival graft, 2 mini strips on the palate. Why strip and not of one big free gingival? No pain. There is no pain. If you take a 2 millimeter strip and another one and leave this alone, that's granulating without any pain. And then you cut, you suture around the healing abutments. So now you have keratinization of the lingual, keratinization of the buccal, and see, it's beautiful. You have keratinized tissue everywhere. There is no problem with the vestibule because once you bring the bone up, there's no problem. Then there's 3 crowns. And if I show you this patient, you think no bone graft was done here, no defect. It's like normal teeth. And I like this, 3 teeth not connected. 3 teeth not connected. But I asked the prosthodontist to change this crown. I don't like this flag. Why don't you bring a little bit down here and a little bit here so you can be more cleansable. This one, same thing. And this one has some, this is the bone, has some keratinized tissue, but no keratinized tissue in the lingual. I've done the mini strip gingival graft on the lingual and ended up with keratinized tissue 360 degrees around the implant. And this is one of my favorite pictures, as this one, and especially this is this. See that? This way it is hygienic. Now, the anterior mandible. Okay, so we have quite a lot of patients coming like this. Previous implants failed and things like that. This patient has, remember the terminal branch, It is so small you can cut. But before you cut, put a suture. And cut here, don't cut here. Okay? You put a mini suture and then you can cut. But then you will have this. What is that? I sent this picture to the anatomist in the university. I asked the anatomist, what is this? He says, I don't know. This can be the Wharton duct or the real terminal branch. Which one is it? Let's take a look. Let's prepare the cadaver. This is what I want to know. Then we started to inject from the carotid artery. And we found it's an artery. It's the terminal artery. It's the terminal artery. Okay, so this is the terminal branch. This is the Wharton duct. But now it's coming out of the dense connective tissue. So it's not protected anymore in the dense connective tissue. What do we have to do with this? Okay, so we make 2 vertical incisions on the lingual because it's the 3rd zone. Remember, 3rd zone from here to here. The entire anterior mandible is the 3rd zone. It's the most important zone. We make the flap. This is the genioglossus muscle. Then parallel, scratch, and then we stretch it up. There is one artery behind this, one artery behind this. All we need to do is stretch, stretch, stretch. And then we're going to have these. This technique is the lingual flaps is best to practice on a cadaver first. Okay, fixate on the lingual, fixate on the buccal, close completely, and then you can place your implants. 2 parallel CC 375. I don't want to place the 4.5, 4.3 is usually 375 is a very good size. It's a perfect size for regenerating bone. Okay, 4.3 I will place for a single back in here. Okay, this part of the mandible did not exist. Okay, let's take a look at this. You go all the way down, all the way down. Okay, now mini vertical incision here. It's moving a lot. Okay, let's take a look at the cleaning of the teeth, the lingual flap. Okay, that's going to be the most important. Look, watch now. Cleaning, a little bit more degranulation. There was an implant here, remember, I showed it in the morning. Now, with the back end of the blade, one artery is there. Next artery is going to be here, behind, between the periostome and the dense connective tissue. Stretch up one, stretch up the other one, stretch up here, and now I like to play with this. See that? Just play a little bit with this. Then I'm going to fixate the membrane on the lingual. With a screwdriver and a handpiece. 2 screws. Then I can place the bone graft. Okay, I'm not going to show the full closure here, you will see it after. That's it. Okay, we got the membrane in here. Put a screw or a pin. You have Mazinger here? Mazinger is here. Yeah, so master pins. Then you're gonna have to cut it back. Remember, it's still too close. Okay, I cut it back. Then this will heal. I remove the membrane. Okay, there is the cross section. I'm going to place the implants. 2 375s or 3.5 noble active or 375 parallels. But now I will have to place it deeper. See, it's not moving, very strong bone. I'm going to put it deeper, more apical. And I put 2-on-1s, which are supposed to be for single teeth, and actually you can connect them as a bridge. Why is that good? Because you can screw it in. You can screw it in and it doesn't come out anymore. Then I can do mini sausage in here. That's how this is going to mature. And you can do a mini sausage, collagen membrane, collagen matrix. This is like a piece of fiber guide for thickening. And look at that, the bone is into perfection. Bone is into perfection for this. Okay, so okay, now what do you say? This patient had 4 coolie plates, 4. 2 from here, 2 from here, and 1 hip graft. This is paper thin. Patient was sent to me from the Netherlands. Oral surgeon calls me from the Netherlands, maxillofacial surgeon from the insurance company. Istvan, forget it, you cannot treat this patient. We're not going to pay for it. I said, well, come next week and watch. How do you do it? I just scrape. There's a little piece of bone here. I just scrape it off and do a lasagna. Look at that. 3rd zone. Zone 3. From here to the other side. I'm going to go on the lingual. I think the LED screen cannot follow the video. Okay, I'm gonna fixate on the lingual. Very easy to fixate with a handpiece. 100 RPM, it's in. Look how much bone I scraped. I used 4 scrapers. Mixed with the anorganic bovine bone mineral, the xenograft. Put a layer of lasagna. Fixate it all the way out. Here, pack some more bone. And now I'm going to have to go on the lingual and on the buccal to advance the flap. But we understand how to advance the flap now. We all understand. Scratch through the periosteum. Stretch it all up. That's the ganglioglossus muscle. The salivary gland on the buccal, around the nerve. Cut around the nerve. Do the same thing. Do the bundle, debundle, and the stretch. Close it here, close it here. See, I can put my finger underneath here. It's so loose. There's no way it's going to open up on you. No way that this is going to open. See, this was the defect. Remember, this was super thin down here. That's why you cannot place implants deep. So I brought very thin, bring it all up here. Biologically, the most difficult bone graft is this. Biologically. Narrow down here and wide. Look, narrow down, but look how much bone. Scraper. What do you think? Oops. Okay. There it is. It's cortical bone. It's a new mandible. Okay. This patient was sent to me from New York. They wanted this type of implant. I place that, but normally I place this one. I do a gingival graft on the lingual, on this one. But I want to show you this patient. Okay? That's a Brenner mark implant. That's a on one parallel CC. And here I ordered, I don't think you can order anymore, the old Brenner mic with the machine. Can you order? Before you could order 50% extra, and I wanted to place 2, and this was the patient, a couple of years ago, maybe 8 years ago. Okay, I'm gonna stop this. Look, I think the video was better, because now it's moving. Not too much? Now we enlarge it, but it's moving all the time. Too much. Yeah, the smaller is better. Can he put it back? Because we blew it up, but now the movies are like... Because there's a lot more videos coming. Let me drink. That's me. Okay. Let's do this again, okay? Much better. Videos will be much better, as you see. Okay, so look. I'm removing this membrane. What is interesting here is that that's like a noble surgical guide. And look, maybe you have never seen an implant like this. This is the classic Brenner mark implant. Okay? Machine, very good implant, but it's outdated today. And I wanted to order, but this one, because of this, I couldn't put it deeper. And I got stuck here. This is mobile, you will see. Smear layer. I will lose 2 millimeters of bone. So, if I am going to do, unless I'm going to do something, and that's something that I want to show you. Putting it, see that? This part of the bone? Not good. Will disappear. See this part of the bone? Not good. I mean, it's a smear layer. I should put in the implant like the one before, like 1.5 millimeters deeper. But this implant has a configuration that I couldn't do it, okay? With a parallel CC or whatever implant you use, you can put it deeper. Good. Now, what do I have to do to prevent the bone loss? Mini sausage. Okay? Either deeper or mini sausage. Let's do mini sausage. Okay? What does the mini sausage consist of? It consists of about 70 to 80% of the BIOS, or a xenogenic bone graft, and some autogenous chips. I'm going to use a pin or a microsuture. There's a little scar tissue here. Just make one little incision in the scar tissue. Now I'm going to suture this, and I put in 4 vertical metal sutures. 1, 2, 3, 4. Then I close. Now take a look what happened to the bone. No bone loss at all. See that? Perfect bone around the implant. Buccal, lingual, interproximal. Okay, that was my message, the mini sausage. Okay, so the last